Hello, everyone, and welcome to this evening presentation. I am extremely honored to introduce to you Professor Ben Pfeifer. For many years, the Really Healthy company has promoted Professor Pfeifer's pioneering work in the UK because we feel that the multidisciplinary approach it takes is essential for those who have run out of options. Today, Professor Pfeifer is going to give an updated talk on his Prostate protocol, covering updates he was made as well as new treatment successes. Professor Ben Pfeifer is the founder of Integrative Cancer Care, an online platform powered by Aeskulap International. He is leading an international medical consultancy team of oncologists, immunologists, and other medical specialties that provides second opinion services and treatment recommendation for an international patient clientele. He is a widely published clinician and researcher with over 70 publications in peer-reviewed medical journals. The first textbook on integrative oncology, numerous papers at national and international medical conferences, and invited lectures at the prestigious Academy of Science in Germany, Russia, Poland, and the USA. With more than 40 years of medical experience in various medical fields, Professor Pfeifer has pioneered a new treatment approach to cancer, combining leading-edge conventional treatments with effective complementary oncology measures, achieving better patient outcome, improved quality of life, and longer survival of patients with metastatic cancer. So Professor Pfeifer is currently in Indonesia and is not able to have a finely tuned internet connection, and therefore he has tried to pre-record the presentation earlier today just for us. So it should be working absolutely fine. So Professor Pfeifer is still with us, and thank you so much for being here today.
Thank you so much, Olivier, and good evening to everybody half around the world. I'm speaking to you from Indonesia. I'm in Bali at the moment, and the pandemic has forced me to stay here. I cannot be closer to you, otherwise I would speak from Switzerland with better internet, but we have tried yesterday, and sometimes audio failed, sometimes video failed, sometimes both. So I decided to pre-record, as Olivier said, but I'm here listening to my own recording and am there for you to answer questions afterwards. I wish everybody a very good webinar, and thanks so much for a Really Healthy company to make that happening. Thank you, Olivier. Back to you.
Thank you very much, Ben Pfeifer. So today, this is the agenda for the presentation, and I will virtually start playing the video so that you can all listen to what Professor Ben Pfeifer has to say.
Can I ask you to come back to the slide one more time, just to give a short introduction? Yes. That would be good. Because I thought it is important to start with a short intro about immune system and cancer, because the immune system function is basically the basis for our protocol, and everything goes through the immune system in the end for our patients. So I give you a 10-minute talk about immunity and cancer surveillance. Then I speak briefly about prostate health and diseases and what can be done from everybody's side who has a prostate to not get sick with this small gland. And the main part of the presentation is what we have done over the years, namely develop a protocol for those men who have come down with prostate cancer, and in particular for a subgroup of them that have not much else to go with, or not much else to go for, and that is the subgroup of metastatic and castration-resistant prostate cancer patients. And after that, we have hopefully enough time for questions and answers. For the next 10 minutes or so, I would like to speak about the immune system and its role in cancer surveillance. Well, we all know that the immune system has to protect ourselves against foreign invaders such as bacteria, parasites, viruses, but also cancer cells. Everything that's non-self, our immune system has to recognize. At the same time, it must tolerate self. That means it must know not to attack our own cells and tissues. Well, that is a very delicate balance act, and if disturbed, infection, cancer, or autoimmune disease may develop. Our immune system operates with two main immunity strategies. The first one is the innate immune system, which our father and mom gave us. When we were born, we have it already, and it works promptly without learning. The main cells in that system are the NK cells, natural killer cells. And then there is a humoral site, which is comprised of the complement system and the cytokines. This system provides physical and chemical barriers to infection, such as our skin, the mucosal linings of our gastrointestinal tract. It recruits immune cells through cytokines to the infection site or to cancer. It activates the adaptive immune system through antigen-presenting cells. And it works immediately upon contact with non-self antigens. The second part is the adaptive immune system. And the major players here are antigen-presenting cells, the T cell system with its various cells like T4, T8, and T regulatory cells, and then the B cell system. And as we have seen it with the innate immune system, here also is the humoral part, and that is mainly consisting of antibodies and cytokine interaction. The adaptive system recognizes specific non-self antigens and can distinguish them from self. It orchestrates a complex immune response that eliminates pathogen-infected cells and cancer cells. For the cancer cells, there's a special cancer immunity cycle, which we will talk in more detail later. The adaptive immune system also creates a memory that is in form of memory B cells and memory T cells. That means on re-exposure to certain antigens, those memory cells come into play and provide faster immune responses. Other than the innate immune system, which works properly upon contact, the adaptive immune system takes time, usually 5 to 7 days, for it to make a good and sufficient immune response. Now here is a view of the cancer immunity cycle, and it starts with liberation of cancer antigens. That can happen spontaneously or through the influence of toxic treatments like chemotherapy or radiation treatment. Those cancer antigens are then taken up by dendritic cells or other antigen-presenting cells. Those then presented to lymphocytes, in that case T cells within the lymph node, and here interactions between antigen-presenting cells and T cells happen. The activated lymphocytes, activated T cells that is, are then migrating through the blood vessels to the tumor site, and there they will infiltrate tumor microenvironment, that means the tumor tissue. Once in the tumor tissue, they will recognize and bind to the tumor cells, and finally they will initiate cancer cell killing. Now that cycle repeats and repeats, but in order to protect our own cells and tissues, there are certain checkpoints built into that cycle, and that is one checkpoint between antigen presentation by the dendritic cell and the activation of the T lymphocyte, and a second and a third checkpoint will be between the undocking of the T cells and the cancer killing itself. Now we look at those checkpoints a bit more closer in the next slide. Here you see the antigen presentation and the T cell interaction in the lymph node. And on the right hand side of the slide you see what happens with the activated T cell and the tumor cell. Now the first and most important step for interaction is that the antigen presenting cell on the left plus the T cell bind with each other, and that happens through an MHC complex and the T cell receptor. That is the same principle on the other side, where T cell reacts or interacts with the tumor cell. For that interaction, there's some co-stimulatory factors important. B7 and CD28 are here listed, and when that also comes into play, then the so-called CTLA, which stands for cytotoxic T lymphocyte associated protein, on this side, and here the PD-1 receptor on the T cell, they will not be activated. That means on this side antigen presentation can happen, an activation of the T cell, and on this side they not activated will allow tumor cell kill. Once they are activated, the immune response is basically suppressed, and that is the case for the presentation of the antigen, but also the case for the cell killing. Therefore, checkpoint inhibitors were developed. That means substances that can block this inhibiting complex, and that is an anti-CTLA, and on this side, and here it is an anti-PD-1. So that means a blocking substance that takes the brakes off the immune response. Now for this finding and for describing this, James P. Ellison got the Medicine Nobel Prize in 2018. Now, in the meantime, we have several substances that are FDA approved and also already used in the clinic. For the CTLA inhibitor, for example, ipilimumab, for the PD-1 inhibitors, Opdivo and pembrolizumab, and nowadays there are already PD-L1 inhibitors in play and in clinical trials. The last slide shall show you the reasons why that immune response that I just described is not killing all cancer. Cancer cells are very smart, and they develop early on mechanisms to disturb the immune cycle or immunity cycle against them, and they develop mechanisms to escape the immune system. One of those mechanisms is the loss of antigenicity, meaning they develop clones that just do not show any HLA, that do not have the passport of cancer cells to show. Another level of escape is the loss of immunogenicity. That means, for example, some cells will express small molecules that are immune suppressing, or they will just overexpress on their cell membrane PD-L1, and when that is overexpressed, this switches off the immune response on the cell killing level of the cancer cell. And last but not least, in the cancer environment, there may attract T regulatory cells that switch off immune response against cancer, or certain macrophages that do the same. So overall, the immune response against cancer will be reduced or even switched off. This is the reason that we have 20 million new cancer cases per year, and those cancers have overwhelmed or tricked the immune system of their victims. Therefore, a strong immune system is the best guarantee for healthy aging without any cancer. However, it does not protect you against weak street signs. Let's start with prostate health and disease. The prostate is a very small gland, about walnut size, and it's located between the bladder and the anterior rectal wall. It wraps around the urethra of the man and is connected to the seminal vessels. It produces a thick and milky white fluid that becomes part of the semen. You can understand that problems with that little gland will affect urination and sexual function. There are three major diseases: prostatitis, which is inflammation and infection of the prostate; benign prostatic hypertrophy, which is an age or aging-related enlargement of the gland; and finally, prostate cancer, which is the growth of cancerous tissue within or elsewhere in the body of prostate cancer. The PSA, prostate-specific antigen, is a marker that is used for all three diseases because it's a tissue-specific marker, not a tumor-specific marker, and it is elevated in all three of these conditions. Prostatitis is the inflammation of the prostate commonly caused by infection. There's an acute and chronic form. The chronic form is very difficult and debilitating to the man. Burning or painful urination is one of the symptoms, trouble with urinating, difficulty and painful ejaculation, and finally plain pain in the perineal area, that is the skin between scrotum and rectum. For the treatment, there's antibiotics. However, as mentioned before, chronic prostatitis is very difficult to cure. Benign prostatic hypertrophy is an enlargement of the prostate that in the end will compress on the urethra and make urination very difficult. It affects about 3/4 of men over age of 60. By the age of 80-90% of the men will have some form or other of benign prostatic hypertrophy. We think that an imbalance in testosterone and estrogen with age will contribute to extra prostate tissue growth and be one of the reasons for benign prostatic hypertrophy to happen. Compression of the urethra slows down urination and in some cases even stops urine flow totally. It does not seem, though, that it predisposes to the development of prostate cancer. Symptoms can be divided in three: voiding problems, irritation problems, and clear impact on quality of life. Voiding problems, straining, decrease in urinary stream, dribbling, and so on. Irritation problems, urinary frequency, so men have to run to the bathroom many times in an hour. Dysuria, nocturia, that is the nightly way to the bathroom, and also incontinence. The quality of life is impacted by anxiety, depression, and less sexual activity and the psychological problems that go with it. Medication is the mainstay of treatment. However, overall, it has a low compliance due to the side effects. The drugs most often used are alpha blockers and 5-alpha reductase inhibitors. If the problem becomes non-responsive to the medication, surgical treatment might become necessary. The classical treatment is the TURP, transurethral resection of prostate cancer, laser ablation, and in extreme conditions, meaning when this prostate tumor, benign tumor that is majorly large, then open prostatectomy needs to be done. Prostate cancer is a cancerous growth within the prostate or outside the prostate. Then it's invading bone, or it is invading the rectal wall, or the seminal vessels, or may cause even remote metastases. Aging is a major factor. Lifetime risk of prostate cancer is 1 in 7 men. Although we don't know a real cause, we know that diet and environmental factors play a major role. In Europe in 2020, we had 500,000 cases of prostate cancer, and worldwide it was even 1,300,000 new cases, and 365,000 men died of this disease. So you can understand that it has become a major economic burden for society. In 2010, in the US alone, there was a cost for treating prostate cancer that exceeded $12 billion. The symptoms are often late, therefore about 20 to 30% of men will get the diagnosis once they are already metastasized. There's some voiding problems, some irritation problems that are similar to benign prostatic hypertrophy. Bone pain may occur when there is metastatic disease. Treatment is done by a radical prostatectomy and radiation. Radiation can be applied as external beam radiation and as brachytherapy. Brachytherapy is when you go into the tumor with either seeds or a catheter and apply radiation directly to the tumor, not through the skin. Although these treatments are considered gold standard and curative, there is a 50% failure rate. Many experimental treatments therefore are available because none of them, HIFU, ERA, hypothermia or embolization, are perfect. LUTS, that is a lower urinary tract symptom complex that can be the end result of all 3 prostate diseases: prostatitis, benign hypertrophy of the prostate, and prostate cancer. It is burdensome because it always comes with urgency, with nocturia, with incontinence, and with the psychological problems that we have already discussed. It is estimated that LUTS affects 2.3 billion people worldwide, so you can imagine how much it costs our societies. In the US alone, again, there's a number from last year that is $3 billion US dollars. The current medical treatments we have already mentioned are alpha blocker and 5-alpha reductase inhibitors. They are effective, as I said, but the effects are causing also side effects, and the patients therefore have a very low compliance. Nutritional supplements have been tried, like vitamin C, D, pomegranate and cranberry extracts. We like to give imipros and prostalin C to our patients with LUTS or LUTS symptomatic. They are helpful. Pelvic muscle exercise and bladder training, physical activity, dietary modification, all can alleviate the symptoms of LUTS and improve quality of life. So what can we now do to maintain prostate health so that it doesn't have to come to disease? We have lifestyle choices that are having an impact on disease incidence. Therefore, it is always good to look at his own life and his lifestyle choices. Epidemiological studies have shown that 50 to 70% of all solid tumors are preventable by balanced nutrition and healthy lifestyle. So that certainly is not the best balanced food and nutrition, while that is a balanced lunch dish. We know that prostate cancer incidence depends on what men eat. If you look at the countries and their incidence of prostate cancer, then you see the USA, that is the #1 fast food country, has the highest incidence. And China, on the other end of the spectrum, where food, at least in the urban areas, is still cooked from scratch, you have the lowest incidence. We know also that our Western European diet has way too much animal fat. If you look here, North America with animal fat of 40% and vegetable and fruits 35%, and then you go to the Far East, the vegetable and fruit content of their daily food intake is about 80%, and the animal fat only 6%. We also know that too much sugar is responsible for prostate cancer and other cancers. In 1970, there was about 4 kilograms of refined sugar that were eaten by each person per year on average. Today, it is about 50 kilograms of refined sugar that are consumed every year per person. High sugar consumption, we know, is increasing prostate cancer, but also colon and pancreatic cancer. Overweight and not enough exercise. We know that overweight should be avoided at all costs, since it increases risk of metabolic syndrome, diabetes mellitus, hypertension, heart disease, lung disease, and many cancers, including prostate cancer. Obesity is clearly connected to prostate cancer, but also to a list of other cancers that is shown here. It is estimated today that Europe has 3% of all cancers in men and 7% of all cancers in women, which are based on obesity. So it is a very good strategy to not accumulate overweight. Cigarette smoking is responsible for a lot of diseases. 80% of lung cancer, 70% of chronic lung diseases, and the list goes on. There is estimated that yearly around 300,000 deaths are due to smoking in the US. And that is a cost of $60 to $80 billion. It is further estimated that the yearly deaths and economic loss to smoking in the UK is about 100,000 deaths and about 10 billion pounds. The WHO estimates that the global number of deaths related to cigarette smoking is around 7 million people per year, and the global economic burden is around 500 billion. So an enormous health cost and a society cost is the cigarette smoking. Too much alcohol. There's an old German saying, ein Gläschen pro Tag kann doch nicht schaden, meaning so much as 1 glass per day can't be too bad. And certainly the size of the glass will play a role. We know that the relation between alcohol consumption and cancer is not as clear as for cigarette smoking. Red wine may even be beneficial for some cancer patients. However, regular and excessive consumption of alcohol is clearly not healthy. Liver cirrhosis and cancer of the oral cavity, pharynx and esophagus may arise, and there might be an increased risk of breast and intestinal cancer due to alcohol consumption. Remember, preventing is better than treating. Regular physical activity, low animal fat intake, no smoking, and if possible, chemoprevention with selenium, vitamin E, lycopene, epigallocatechin gallate, imupros, prostaline C, and BioBran. We have written about this already in the year 2003. And for those who are interested, I'd be happy to provide that article. Now we come to the main part of my presentation, integrative treatment approach for patients with metastatic prostate cancer. And I would like to start this with a number game. An adult human consists of 35 trillion cells. that is 35 and 12 zeros behind it. Almost 70% of that are red blood cells. We also have 40 trillion non-human cells living in our body. These are mainly bacterial cells in the various microbiomes. Every day, about 4 times 10 to the 10 of our cells die and are replaced by new cells. The replacement is orchestrated by our adult stem cells present in all of the 200 plus cell and tissue types in our body. Assuming that we grow to be 80 years, then that is approximately 30,000 days. And we have to multiply this by 4 and by 10 to the 10. This results in 1.2 quadrillion cell replacement in our lifetime. Of course, with so many cell replacements, DNA copy errors will happen, and they may result in mutations. And if there is enough mutations accumulated, then cancer will develop. Adding to that, our environmental pressures through the thousands of carcinogens in our daily life, then bad nutrition and immune depression from negative stress, in particular during the pandemic, we will understand our cancer statistics better. More and more cancer cases and more cancer deaths. This graph shows you the situation over time. On the y-axis we see the cancer incidence in the world, and here are the years, and you can clearly recognize that there's a steady increase to about 20 million new cases in 2020. And also the people who die from cancer are increasing constantly, and in 2020 it was between 12 and 13 million. The UK situation is 380 to 400,000 new cases per year, and of those, maximum of 200,000 people will die. 50% of all cancer deaths come from lung, bowel, breast and prostate cancer. And it is only 1/2 of the cancer patients who will survive more than 5 years. It is estimated that 1 in 2 people in the UK born after 1960 will be diagnosed with some form of cancer during their lifetime. That means 1 in 2. 35 years ago it was 1 in 30. We also know that 1 in 7 men in the UK will get prostate cancer in their lifetime. Looking at the survival curves of patients with prostate cancer, we clearly can say it depends on stage of the disease. While stage 1 patients will enjoy a 5-year survival in 80% of the cases. However, stage 4 disease will only survive in less than 10% of the cases. Most publications say 2 to 5%. Here are some interesting prostate cancer facts. 20% of all prostate cancer patients are diagnosed with advanced disease. That means when they come to the doctor because of back pain, the disease is already out of the prostate and bone lesions have developed. 50% of prostate cancer patients advance to metastatic disease even after curative treatment. 100% of patients with advanced prostate cancer will receive hormone ablation therapy. Now that is given in the palliative setting when the cancer is out of the prostate and involves development of metastases. All of those 100% of patients with palliative hormone ablation therapy will develop a disease form that's called castration resistant. That means they will not respond anymore on the castrating medication. The cancer will continue to grow. This slide shows us a summary of the present treatment options for metastatic disease. And there is, of course, the first-line hormone ablation with these three representatives, and I have written underneath the drug name the approximate cost per month. Then we have a second-line hormone blockade with very new and costly medications like Zytiga and Xtandi. Then we have immune therapy option, and although they are all theoretically possible, checkpoints, vaccines, adoptive immune transfer, at the present time only the vaccine is in really clinical use, and you see how expensive 3 treatments of the vaccine Provence or Cipuloid sale is. Then we have chemotherapy with docetaxel, Taxotere mainly, but also with cabazitaxel, and in few patients still metoxantrone is used. We know that these treatments will only get a gain in survival that is measured in 2 to 3 months. And look at the price for cabazitaxel of 6 cycles. Bone protection with medication is affordable, but with the newer radiation technologies, it's quite expensive. Finally, we have our own protocol that we use since about 20 years, based on antioxidation, anti-inflammation, anti-angiogenesis, detoxification, phytotherapy, and immune support, which costs about 250 to 400 pounds a month. Despite all these newer conventional treatment options for metastatic prostate cancer, the outlook for those patients is still not satisfactory. The improvement of disease-specific survival with the conventional treatments is usually measured in months only. For example, chemotherapy, 2 to 3 months. The newer second-line hormonal blockade medications, 4 to 5 months. If we look at a prostate cancer patient with multiple bone lesions, it's fair to say that his 1-year survival chance is 45%, and his 5-year survival chance is probably around 5%. Now, can we do better? I think yes. By using an integrative treatment approach to metastatic prostate cancer, I think we can do better. Of course, we use leading-edge conventional therapies in conjunction with dietary interventions, with physical exercise, with psychological therapies, with the triage of antioxidation, anti-inflammation, and anti-angiogenesis, with immune modulation and support, with detoxification treatment, and with phytotherapy, all in the goal to achieve long-term cancer control. I'm not talking about curing this disease, I'm talking about providing time for the patients, and time with improved quality of life. Now, let's start to look at dietary measures and detoxification. It is estimated that 70 to 90% of all cancer is caused by environmental factors. Often petrochemical toxins and heavy metals are accused of causing cancer after they affected our bodies for a long time. And of course we cannot do much against that, but we could do something for good lifestyle choices. So for example, not smoking, as I mentioned earlier, not heavy drinking, no recreational drugs, and no lasting negative stress. So bad nutrition is also a situation that we need to overcome. So not every day to Burger King or McDonald's, but preparing our meals. We have a simple program, daily hydration with about 2 liters of ionized water, pH usually between 8.5 and 9. Reduction of animal fats and more fresh vegetables and fruits. reduction of caloric intake, so don't get fat, keep your normal weight once you have prostate cancer, intravenous chelation therapy and other detoxifying measures to reduce heavy metals. We do that with cyclic detoxification with an activated zeolite called DetoxMe. I will show you that in the next slide. That is DetoxMe under the microscope. It's a raw material from volcanic rock, contains silica and aluminum that is tribomechanically broken down to almost nanoparticles. In that process, and that's the interesting part, in that process, these particles increase their surface area and take on biological properties. They are a strong ion exchanger. They are detoxifying by absorbing those toxic substances. They have antioxidative and immune modulating effects. Green tea is added after the micronization, which also has similar effects as the zeolite itself. Here you can see the product that is sold under the name of DetoxMe, and we have done a clinical test together with SwissTech, an offspring of the ETH Zurich, which is comparable to the MIT in the US. DetoxMe removes heavy metals like lead, cadmium, mercury, nickel, and arsenic. It removes even aflatoxins and other pesticides. It can remove radioactive nuclides such as strontium and cesium. Therefore, it was used basically in its raw material form to dump over the nuclear reactors in Chernobyl and Fukushima. It attracts and buffers excess protons. It activates macrophages and it stimulates some of the immune cells. If we look at the second part of our integrative program, which is antioxidation, anti-inflammation, angiogenesis inhibition, and phytotherapy, to achieve proper antioxidation and anti-inflammation, we use a compound called Imupros. This is a automolecular preparation and manufactured with a special galenic technology, namely time-release tablets. With this mechanism, the individual ingredients of Imupros are released in the gut at different times, so they cannot react with each other and interfere with absorption. These are the ingredients list, and you see there's vitamin D, vitamin E, vitamin C, there's some calcium, there's soy life, these are isoflavones, selenium, lycopene, zinc, and green tea extract. Now, this preparation provides important vitamins and minerals and other vital substances in one tablet. Its proven efficacy of all individual components for prostate health. We do recommend 1 to 2 tablets for chemo prevention. And in case of disease, for example, prostatitis and prostate cancer, we increase that dose to 2 or even 3 tablets a day. This slide shows us the 9 preparations that we use in our phytotherapy protocol. They're not used all together for each patient, but selected according to the patient's situation. And we have 3 groups here. The first group do have direct prostate cancer effects. They reduce prostate cancer cell growth and force apoptosis. The next 2, they have something to do with metastases. They reduce the metastatic potential of circulating tumor cells. The last group of 2 preparations, they have clearly immune supportive and immune modulating effects. Now, phytotherapy is not that easy as many people thought. just give as many drugs as possible and it will do something. Here we have a patient that had to take almost 100 capsules, tablets and drops, powders per day. This certainly is not the way to do it, and probably too much for even the strongest patients. We use Prostasol for almost every patient with prostate cancer. It is a concoction with 9 medicinal herbs combined with lignans and with biocurcumin. It inhibits cancer growth in the laboratory. It reduces PSA in the animal experimentation, and in humans it reduces metastatic pain. It is, and that's probably its best feature, it is even efficacious in castration-resistant prostate cancer. We have some experimental and clinical results. It inhibits cancer growth dose-dependent. It downregulates PSA expression and androgen receptor activity at the prostate cancer cells, and it sensitizes prostate cancer cells to heat and radiation. Down here you see the 2 publications that described these effects. Curcumin combi is a biocurcumin complex extract from the turmeric root. It also contains resveratrol, which is coming from the Japanese knotweed, and some quercetin. There's many experimental results in the PubMed library. For example, for curcumin's direct anti-cancer effect, you can find more than 5,000 papers published. For its anti-inflammatory effects, there's over 500 papers published. And for its angiogenesis effects, you have more than 10 papers published. So there's a huge body of peer-reviewed and non-peer-reviewed information on the internet. The next compound we use in our protocols is Artemisia annua, an extract from sweet wormwood. It has been shown to have significant anti-cancer and anti-malaria efficacy. Matter of fact, the WHO is recommending this compound for treatment-resistant malaria strains. Experimental research work shows that Artemisinin inhibits the development of cancer and cancer growth. There's 350 PubMed articles published. It also has anti-inflammatory effects, and there's 100 plus articles for that published. And finally, similar to curcumin, Artemisinin also has effects on angiogenesis. It inhibits the new development of blood vessels in metastatic disease. There's about 50 articles published for that. We also use indole-3-carbinol and DIM, a metabolite of indole-3-carbinol. And you all know that extracts of cruciferous vegetables result in a high concentration of indole-carbinol that could be used for food supplement production. It contains 200 milligram I3C, 5 milligram of resveratrol, and some vitamin B12 per capsule. Indole-3-carbinol increases the turnover of estradiol to estriol, which is a weaker estrogen, and thereby inhibiting growth of breast and prostate cancer. It also increases apoptosis, which is the induction of normal cell death. It inhibits prostate and breast cancer cell growth through interference with signal transduction. It is effective in hormone-independent prostate cancer and breast cancer, and it is recommended at a dose of 400 to 600 milligram per day. Now we come to immune modulation and immune support in our integrative approach. And here I would like to discuss BioBran, our dendritic cell vaccine, and our designer peptide vaccine that we use in prostate cancer. BioBran seems to be the strongest NK cell stimulator available today. It comes in sachet form as a powder and in tablets forms, and there are more than 30 peer-reviewed articles in the US National Library of Medicine. When you compare the effect of BioBran on the NK cells, you can see it's much larger, 4 or 5 times as much as other arabinoxolans, and at least 2 times to 3 times as much activity gain when compared with active hexose compounds. That means it is a strong stimulator of NK cell numbers and also NK cell activity. We have often measured the NK cell function, number and activity, that is, of patients with metastatic prostate cancer. And here you can see what intake of 2 grams per day, 2 sachets per day does from week 1 to week 6. And here you see the increase over baseline NK activity. And of the 15 patients, almost all showed an increase of 150 to 200% in maximum. There was only one in this group that did not respond well, and he also had very, very aggressive cancer and died in week 7 or 8. So what this graph shows you is that it's not only increasing NK cell function in the laboratory, but it is a real compound for the clinic. That this compound has clear clinical relevance is also shown in this slide. Here in 2004, a Japanese group examined stage 3 and stage 4 cancer patients with progressive and metastatic disease after they had received conventional treatment, including chemotherapy. One of their endpoints was the 2-year survival rate of those patients, and they had 2 groups, a BioBran group and a control group. And you see in the BioBran group, there was a survival at 2 years of 54% compared to the control group only 34%. This difference became even more evident if subgroups were established, subgroups that had only less than 20% NK cell activity when they entered the study. And when you looked at the 2-year survival rate of those patients with less than 20% of NK activity, you see that 42% of them survived compared to only 12.5% in the control group. Now that is a clear evidence that high numbers and activity of NK cells are helpful for cancer patients. This slide shows you our approach to dendritic cell vaccination, and it starts usually with either a blood withdrawal of 180 to 200 cc or a leukapheresis where monocytes are isolated, and these monocytes then will be cultured. On this side we see that at the same time, if we have a tumor biopsy of the patient, or if not, we use proprietary polypeptide antigen for what is called the priming process. These isolated monocytes go then into the laboratory in culture and are primed with the respective antigen. We wait for maturation of the monocytes into mature dendritic cells, and these cells that now carry the information of the tumor of the patients are then injected as a vaccine. We have another vaccine approach, a designer peptide vaccine. It starts with sample extraction. We need some tumor cells for next generation sequencing. That means we look at DNA mutations. When the sequencing is done and the analysis is done, then we identify tumor specific mutations and the HLA type of the patient. When that is done, a large bioinformatic analysis starts and prediction of immunogenic peptides that are based on the mutations found is done. From the peptides prediction, we are then producing those peptides and putting them in a vaccine vial, and then the vaccine is used together with a vaccine adjuvant. Together with SEGAT, Germany's largest human genetics institute, we administer this program, and we have already close to 200 patients. The first impression is very good with disease stabilization and cancer reduction. Now, what can we now achieve with all that for an individual patient? And that is best shown probably at a patient example. We have here a metastatic castration-resistant prostate cancer patient. At age of 56 years, a businessman from Venezuela was diagnosed with treatment-resistant back pain. A PSA was measured and it was 87.4 nanogram per cc. A biopsy revealed prostate cancer. The CT showed multiple bone lesions and lymphadenopathy. After about 6 months of successful hormone ablation therapy, the patient unfortunately became castration resistant. The PSA increased over the next 5 months to close to 2,800, and bone pain and tumor anemia were observed. The patient refused chemotherapy with mitoxantrone, which at the time was the only treatment for his situation. The physicians told him to go home and die. He started our protocol in January of '98. I was still in the US at the time. We used a precursor of prostasol, we used some curcumin, BioBran, later Imupros and indole-3 carbinol, and from 2003 onwards, DC-Vaccination, regular detoxification, and hypothermia. This shows the patient's bone scan with plenty of metastases in the head, in the spine, in the rib cage, in the pelvis, with the consequence of significant anemia and bone pain. This shows the course of his phytotherapy. Treatment was done and forced the PSA down quite quickly, over a year and a half, to close to 1 nanogram per cc. The bone scan after 2 years of phytotherapy resulted in a major reduction, no more pain, and the life quality actually was good. Treatment result after 18 years, this is, in October of 18, the PSA at that time was 0.26. There was no bone lesions visible in the choline PET in 15 and in the PSMA PET in 18. There was no bone pain and no anemia. The patient was mobile, active, back in business, and with good quality of life. Now, this is Mr. Petrini in December of 2020. We did an interview with him because he indeed is the oldest patient alive with 22 years of metastatic and 21 years of castration-resistant prostate cancer that I know of. Before I was diagnosed, I felt invincible, but everything changed. I was now vulnerable, but decided to fight. I really was afraid, and I consulted physicians at famous hospitals everywhere, in the US, in Europe. Everybody said the same. You have very limited time, make no plans, prepare to die. My treatment consisted of nutritional supplements according to Professor Pfeifer's protocol, plus hypothermia. There were no side effects to speak of. I felt good throughout, and my PSA level quickly went down to 0. You can watch the entire interview on our YouTube channel. I wanted to show you our clinical studies in men with metastatic and castration-resistant prostate cancer, because I know one patient's disease course is no proof. But we have some good study results as well. There's 3 studies done over the last 15 years that show basically similar results. The first study was a prospective study with only 16 patients, still done at the university where I was, and published in British Journal of Urology. We saw that 11 of the 16 patients had a more than 50% PSA reduction of metastatic pain, and improvement of quality of life with our protocol. The second study was already involving more patients, also a prospective study design. It was published in 2005, started in 2004. 84 of the 174 men studied showed the same decrease in PSA. We measured also tumor volume in those men, and that also showed a significant reduction with the protocol. The last study went on for many, many years, 13 years in total, and we looked at 500 patients, but in a retrospective way. We saw that 388 of the 494 men were still alive when the study was closed. We had 28 of the 300 alive patients that survived more than 12 years. We had 8 that survived more than 14 years, and we had 2 patients more than 18 years and 1 patient that you just saw with more than 21 years. We concluded from those studies that we actually can do something for patients with metastatic and castration-resistant disease. And I wanted to show you an attempt of superimposing our survival curves with our protocols onto the survival curves known for conventional best care scenarios, adding Prevalence, which is a DC vaccine, and second line hormonal blockade. And you see on those 3 curves that they're pretty much enclosed together. There's only about a 6 to 8 months time gain from the control group to the best scenario, second line therapy and Prevalence. If we put our curve on top of that, that shows then the survival benefits through our protocol, then we see a much longer median survival for those patients. And that with a cost factor of about 300 to 400 pounds a month. I think we can conclude that our integrative treatment approach, including specific phytotherapy, detoxification, antioxidation, anti-inflammation, and immune support, increases quality of life and survival of patients with metastatic and castration-resistant prostate cancer. In the end, please allow me to show you some medical history facts. When physicians went on strike. In the year 1973, physicians in Israel went on strike for 1 month. The number of burials decreased by 50%. That repeated itself in Colombia in 1976. Physicians went on strike and the number of burials decreased by 38%. And finally, 1978, physicians in England go on strike for 1 month and the number of burials decreased by 40%. Now I wonder whether we physicians should go on strike in the interest of our patients. Thank you for your attention. The last slide here shows how to get in touch with us in case you would like more information. Please contact us or contact the Really Healthy Company.
I really want to thank you, Professor Pfeifer, and for sharing so much of your experience. The rate of incidence of cancer, including prostate cancer, is truly on the rise and a grave problem to our modern society and especially our economy. It is truly indispensable that we look at the way we live our lives, and definitely the food that we eat, and also to live a healthier and happier and longer life.
I see a question. Have you had any cooperation from oncologists with your protocol enabling hormone therapy to be used intermittently? Well, there's two questions in one from Patricia. Yes, during the last 15 years, there has been a very good development for us. When I came to Switzerland from the US, no one would want to talk to me. I come from the university in the US and started one of the largest prostate cancer clinics in Switzerland. And of course, there's jealousy amongst colleagues, so we all know that. The urologist wouldn't talk to me, the oncologist wouldn't talk to me. What is Pfeifer doing here in our country? Swiss people are anyway a bit more reserved than Americans or other Western European cultures, but it was very difficult. Over the last 10 years, however, more and more oncologists, not only in Switzerland, but internationally, saw that using the protocol, they can actually do something for their patients. And then step by step, oncologists started dialogue. It wasn't easy at the beginning. It always comes down to a personal good contact to an oncologist, something that is the basis for good discussion, not in front of a group of oncologists, but one or two, then things become easier to talk to. And over the last 10 years, we have worked together with oncologists from all over the world for their patients. This is how we are functioning, that a patient never comes to us exclusively, no. I like to work with the doctors of the patient, providing my experience that I have been able to gain over the last 20 years with this protocol, and helping in guiding the patients of the respective doctors. We have offices in Europe, in the Middle East, and also here in Asia. And it's done in the same way everywhere. The doctor introduces a patient. Our virtual tumor board looks at the patient data, comes up with a protocol, discusses that first with the respective doctor that refers the patient, and then we usually have a Zoom or Skype consult with the doctor and the patient and discuss the protocol. And if the patient wants to go on this route, then the primary doctor is the one who's leading the treatment. And we are only there as a virtual consultant for that patient. That doesn't mean that the patient cannot contact us directly, but he will always remain, or she will always remain the patient of that respective doctor. I think we have not only applied this protocol to prostate and breast cancer because they are so very similar. We have treated patients in stage 4 cancer over 25 years now with variants of that protocol, because in the end, it doesn't matter whether prostate or breast, those cancers are both usually hormone dependent. The basis of the protocol, meaning anti-inflammation, antioxidation, detoxification, dietary intervention, stress, negative stress intervention, all that can be applied to various cancer entities. And we have also learned in the last couple of years that repurposed drugs and metabolic approach to cancer is something we need to do more in the future. One example, we used to recommend metformin for many cancer patients and did not see very much. We increased the dose of metformin. Many of you know this is a typical anti-diabetic, oral anti-diabetic drug. And it is doing something with the mitochondrial metabolism. We have not seen enough with this one alone. But once we started to add an old hypertension drug, so a blood pressure pill called syrosyngopine, we have seen much improvement in cancer patients with stage 4. This is a very simple drug combination that almost all of our patients have tolerated. There was only one that had a little bit of blood pressure decrease. That was, however, only in the first week. The others didn't even show a blood pressure decrease because the amount of syrosyngopine, the blood pressure pill, is very low. We added 6 to 9 milligram of syrosyngopine, combined it with 2,000 milligram, increasing dose over a week time, 2,000 milligram of metformin, and see cancer stabilization in cases that were not stable when they started. So I think there was one question, are we using repurposed drugs? Yes, we do. We also use repurposed drugs to impact the pH balance of cancer patients. You all know that a cancer cell, or let's start at the patient, earlier attempts to alkalinize a cancer patient have miserably failed because we have such strong buffer systems that we cannot force our pH in the blood up from 7.4. This is so tightly buffered, the blood, that all interventions with alkalinizing drugs, with hydrogen bicarbonate, failed. We couldn't do it. We know that the microenvironment of the cancer is very acidic, sometimes 6.9, 7.1, 7.2. But why is it acidic in the microenvironment? Because the cancer cells pump out protons like crazy. The cytosol, that means the inner side of the cancer cell, is slightly alkalotic, meaning 7.5, 7.6, because lactate and other protons are pumped out constantly. There's 2 strong lactate pumps in cancer cells that we can actually inhibit. And syrosyngopine is doing this. Now, if we add other proton exchange pumps, inhibitors, we can even disturb that balance in the cancer cell more and make the cytosol, meaning the inside of the cancer cell, acidic. And we think there is also a good potential to influence stage 4 cancers. Let me read the next question here that I see in front of me. Would you recommend a similar protocol to bladder cancer? I think I answered that already. We noticed that the base of our protocol is applicable to various adenocarcinomas. We have even treated successfully some patients with sarcoma. One patient is a good friend of mine, and I will tell that story briefly. He was told by physicians of Mayo Clinic to have his larynx taken out, that's the voice box, because he had an inflammatory sarcoma of the larynx. He was an avid free diver and noticed that he couldn't free dive so well anymore because there was an obstructing sarcoma lesion in his voice box. Now, when he was prepared for this laryngectomy, taking the larynx out, he had a strange reaction in the operating room. He got up from the operating table, pulled out all of his IVs, and bought a plane ticket to come and see me. And that was 5 years ago. The patient started on an intensive infusion protocol. Our oral protocols, we sometimes give as infusions at the very beginning in stage 4 patients because we know they need more time to respond. It's not chemotherapy. It's changing the interior milieu of the patient. There's no toxicity, but also no toxicity on the cancer. So my friend came with this large laryngeal tumor that obstructed his breathing. We started him on IV medication with the same components that the oral program has that I showed you. And after 5 months, we did a PET scan and his tumor was already majorly down. When we continued that treatment for another 2 months, his tumor in the larynx was gone. That was an incredible situation. You can imagine the pressure that I was on. A friend of mine, and I never expanded that protocol to sarcoma type, which is not adenocarcinoma, which is a different type, mesenchymal cancer. But today, Charlie, that's his name, is still having his voice box. We go diving again, and he is at the moment cancer-free. So I wanted not to brag with this, I wanted to show you there is always a chance, even for somebody who's in stage 4 cancer. Don't let your patient come and be depressed with a non-hope attitude. There's always hope to gain time with good life quality. There's a question I have heard that biopsies could spread cancer cells into the blood. That is absolutely true. We have measured that many times, and I think we were one of the first when RT-PCR came out in the late 90s, 95, 96, 97, I believe. That technology that's used now to look for a genetic sequence of the coronavirus, that's the same test. We use that to find PSA making cells in the blood circulation of our cancer patients after biopsy. And we could see, measuring it before biopsy, then comparing, there's a curve that went kind of like this, up for 2 weeks and then down for another 2 weeks or 3. Up was sometimes so high that we calculated 50 million prostate cells and prostate cancer cells in the circulating blood after biopsy. Now, when we tried to publish this, nobody wanted to hear it. We submitted it 2 times to International Journal of Urology. Nobody wanted to hear that. Matter of fact, I remember vividly a urology congress, European Urology Congress in Berlin, where I was invited to speak. That was in 2003 or 2004, I forget. I was booed out when I showed those results, that the very diagnostic procedure that is used many times over a year, 450,000 biopsies in the US per year, that very procedure could explain the high recurrence rate of radical prostatectomy, the gold standard procedure to treat that cancer, and the failure, that means the biochemical recurrence, PSA increase after the so-called gold standard curative surgery. And I was booed out from stage. That was very, very embarrassing, but I didn't give up. And today I can tell you there's about 100 peer-reviewed journals, peer-reviewed articles in journals that clearly state biopsy will spread cancer cells into the bloodstream and into the lymphatic system. It is the immune system of the patient that has to deal with it and clear it. What we have done then, knowing this, we have recommended to all of our patients with prostate and breast cancer that have a scheduled biopsy to take our biopsy, we call it protection protocol. That is starting 2 weeks before the elective biopsy, starting on the protocol and continuing until the definite treatment, if the biopsy is positive, the definite treatment decision is done. Some patients have started to do that and have taken the biopsy protection protocol for 6 weeks. Then the decision was made, I don't want to have radical prostatectomy, or I would like to have radical prostatectomy, and we stopped. But during that 4 to 6 weeks intake of that protocol, that is 3 or 4 compounds that we use for that, we measured also the decline of the circulating tumor cells every week in many patients. And we saw that we cannot avoid the spread of the cells because that's due to the mechanical needle going through the tumor. But we can speed up the decline. It doesn't take 3 to 4 weeks to be at the base. No, we do that in 1 to 2 weeks after the biopsy, giving a much better chance to get rid of those potential metastatic cells in the blood circulation quickly.
Thank you very much, Professor Ben Pfeifer.
Sorry that
I think this was absolutely amazing. I am absolutely speechless of the amount of information that you have shared today. It's absolutely amazing. So thank you very much. And I just want to confirm to all the attendees, which none of the question could be answered because there was actually so many of them. We will forward them to you, and by the end of the week, you will be so kind to reply to them, and we will redistribute this together with the updates of the recording of the webinar and the slides that can be accessed as well. So
will be my pleasure to answer those, and whoever feels the need to contact me directly, there's always a chance to do so, and I'll be glad to do talk about our protocol, but also get new inspirations from all the people in the audience, because after all, it's always giving and taking. And I say that with a very emotional touch, most of my experience comes from the patients that I treated. And that's a very honest statement.
Thank you so much, Professor Ben Pfeifer. So thank you again, everybody, to have come to listen to the presentation today. I hope you enjoyed it as much as I have, because honestly, I'm very, very impressed with that information and what is and to use in practice. So thank you again, everyone. Have a good night, and everything will be shared by the end of the week. Thank you again. Bye, everybody.
Thank you. Bye-bye, everybody. Go home, or you're all home already, everybody. Be safe and stay COVID-free.
Thank you. Bye.
Bye-bye.